Hello, welcome and thanks for watching this mini-gem brought to you by the Association for Elderly Medicine Education. My name is Mark Garside, and over the next few minutes I'm going to give you a run-through of how to recognise and treat constipation in elderly patients. By the end of this session you should be able to understand the importance of constipation, know why it happens, and know how to select the most appropriate treatment, and also understand when to investigate further. So the first point to make is that constipation is a symptom rather than a disease. However, having said that, it should be recognised as a problem in its own right. One of the commonly accepted criteria for diagnosing constipation is bowel movements occurring less than 3 times a week, but it is a term that means different things to different people. Some would say that they're constipated because they strain to pass stool or because their stool seems very hard. Others use it because they go less often than they expect. It is common, particularly so in older people, but it's not a normal part of ageing. It's also likely to be underreported. This is why it's important to spot constipation and why you should care about treating it in your patients. Aside from being uncomfortable, it can cause abdominal pain. It's also a recognised trigger for delirium, and if left untreated it can progress to impaction with associated overflow diarrhoea. A knock-on effect is also anxiety and depression. It can cause functional decline, but most importantly it's preventable and treatable in a lot of cases. Please be aware that not all older people who are constipated will complain of it as a symptom. It can cause confusion, particularly in frailer people with cognitive impairment. As I said on the previous slide, if there is impaction it can lead to overflow diarrhoea, and it can also cause abdominal pain. It can present with urinary retention, or if somebody is non-specifically unwell with nausea and a loss of appetite, think about constipation as a cause. So why does it happen? Well, as with a lot of things in elderly medicine, it's complicated. There are several contributing physical, social and psychological features which often overlap. Medications can be a cause, as can underlying pathology and bowel disease. If we think about the physical causes first, something as simple as a pyrexia can trigger constipation. Dehydration and reduced mobility are thought to be causative factors. There isn't much in the way of evidence in the medical literature to support this, but it's always good practice to encourage patients to mobilise as able and to maintain good hydration and food intake. With regards to positioning, as highlighted in the diagram here, the knees are meant to be higher than their hips, the spine is meant to be straight, and you should be leaning forward slightly. As you can imagine, this is often difficult to achieve, particularly in an inpatient setting, but it's worth paying attention to. As well as dehydration, a low-calorie or a low-fibre diet can also cause constipation, so check the food and fluid charts and make sure that the oral intake is sufficient. Anything that makes a person ignore the need to go to the toilet can cause constipation, whether that's because accessing a toilet is difficult, whether their usual routine has been disrupted, or whether they perceive a lack of privacy on the ward. These aren't always the easiest problems to address, but being aware of them is a good first step. I mentioned earlier that constipation could lead to anxiety and depression, but in addition it can also be a symptom of those two conditions. It can also present as somatization of other psychiatric or psychological illnesses. There's a long list of medications that cause constipation as a side effect, and a few of them are displayed here on this slide. This is by no means an exhaustive or extensive list, but the drugs shown here are commonly prescribed, particularly to older patients, and you should always review the Cardex to see if there might be an iatrogenic cause for somebody's constipation. Beware also of the additive effect of these medications in combination, and if you haven't already watched it, I would really recommend the mini-gem on polypharmacy in older patients. There's also a long list of pathologies and diseases that can either present with or cause constipation. Common neurological conditions that you might see include Parkinson's disease and cerebrovascular disease. Some endocrine problems include diabetes, hypercalcemia and hypothyroidism. Mechanical obstruction refers to colonic cancer, but can also include diverticular disease or inflammatory bowel disease. Acute urinary retention is listed there as a category in its own right because it often occurs commonly with constipation, and if you treat one then you should look for the other. The old saying goes that if you don't put your finger in it, you put your foot in it, and that's particularly true here. You should always do a rectal exam to exclude fecal impaction, which may change the treatment that you want to offer. Think about potential underlying causes, particularly reversible ones, as we've discussed over the last few slides. When you're sending away blood tests, pay particular attention to the U's&E's, looking for dehydration, the bone panel, looking for hypercalcemia, and the thyroid function tests, looking for undiagnosed or undertreated hypothyroidism. Try and make sure that the patients are exercising regularly if possible and have access to a toilet. as well as maintaining adequate diet and fluid intake. If you do end up using medication to treat constipation, please always do so in conjunction with these other non-pharmacological methods. And that brings us nicely onto laxatives, which you'll often see written in the notes as a plan, but remember that these are a group of medications with different actions, so thinking about the cause of constipation might lead to a difference in choice of treatment. Here are the main different classes of laxatives that you'll see used. Stimulant laxatives work by increasing the intestinal motility. Bulking agents hold water in the stool and increase its weight, making it easier to pass. Osmotic agents promote the secretion of water into the lumen of the colon, and stool softeners are surfactants that ease the interaction of water with the solid stool. Enemas can work in different ways and are used if somebody is fecally impacted, but particularly you should be aware that phosphate enemas can cause hypocalcemia and hyperphosphatemia in ill patients or in those with renal impairment. Whilst all these different agents may have a role in different circumstances, it's perhaps worth noting that the only class of laxatives that has randomised controlled trial evidence behind it in older patients are the osmotic laxatives. That doesn't mean that the others are no good, just that the evidence base for their use is limited. Consider preemptive treatment of constipation, particularly in the post-operative setting if a patient is likely to be immobile for long periods of time. Also, remember that if somebody complains of diarrhea, this can actually be due to constipation and overflow, hence the need for a PR. Consider onwards referral for further investigations if symptoms don't settle with initial treatment, or if they're associated with anemia, rectal bleeding, weight loss, or pain on defecation. In summary, I hope I've managed to persuade you that constipation is a common problem with important consequences. Try to ask about patients' usual bowel habits and think about the cause if they are constipated. Take a common sense approach if possible, and remember that not all laxatives were created equal, so try and tailor your treatment choice to the likely cause. Here's a recap of the learning outcomes, and hopefully now you feel more confident in being able to recognise and manage constipation in older patients. Clinical guidelines on constipation are available from the World Gastroenterology Organisation, and NICE has a good clinical knowledge summary. I also recommend the other two papers referenced here. That's all we have time for today. I hope you found it useful, and thanks for watching.